The motor examination has several components to it. We like to look at tone, power, bulk, which would include looking at the muscle, as you'll see in a minute. And then lastly, we stand back and we look to see if there are any extraneous movements or too little movements. So let's start with muscle power. There's thousands of muscles in the body, of course, and it's impossible to check every single muscle. So in fact, we depend an enormous amount on the patient's history. If a person comes to us complaining of weakness or difficulty walking, falling, trouble using their hand to write or to drink from a coffee cup, then obviously we're going to emphasize those individual muscles. It's impossible to screen every single muscle in the body. So how would you start in a sort of a screening way for an otherwise normal patient? Well, there's a couple of little tricks that we use for doing that. Then I'll show you how to examine individual muscles for power. One of the good tricks here is to get the nervous system to do a natural act. It's easier to tell whether something's wrong with the nervous system if it's having trouble doing a natural act than you putting the person through some unnatural and odd maneuver. So a good one is to put your hands out here, Alan, in front of you, palms up, fingers wide apart, eyes closed, as if you're holding a pizza tray. You're supposed to wait 5 to 10 seconds or so. You can see that he keeps his hands fully supinated, and I often say just make believe you're holding a pizza tray in your hands. Normal. You can relax. An abnormal reaction would be something like this. A person close their eyes, and then over a 5 to 10 second period, you would see pronation and flexion of the affected side. That would be a mild case of a supranuclear, to get back to what we talked about earlier with regard to the facial weakness, a supranuclear kind of weakness, which you otherwise might not notice. And in fact, if you pull and push on the individual muscle, you might not find the difficulty, but you can see this. Same thing can be done with the leg. You have the person lie flat on their back, lift one leg and hold it about 45 degrees above the horizontal, and in about 10 seconds or so, you see that leg sort of in-turn and descend. That's the kind of thing you'd see in a mild stroke, for example, with a hemiparesis, weakness of one side of the body. There aren't too many other good screening tests other than gait, and we're going to cover gait when we talk about coordination. We will watch walking up and down. Gait is another way of picking up a subtle kind of weakness that you might not see otherwise. Well, let's say we were going to examine individual muscles for muscle power. Let me show you how we would do this. Let me have your hand here, Alan. We're going to test the muscles of the thenar eminence. That's these muscles here in the thumb, this big group of muscles here that move the thumb around. We're going to ask the person to hold their hand in this plane, lift that thumb up like that, and hold it in that position, and don't let me put it down. I'm going to put maximum pressure here, and I can't overcome that. Now, when you test a muscle like this, you should press near the fulcrum and not take full mechanical advantage, because you can overcome even a powerful guy like him if you go way far from the fulcrum. So if you turn your hand over, hold that thumb up in this posture, and don't let me put it down, you can see that I can make it come down if I come way out here. So what you do is you go near the fulcrum and you see whether you can overcome this. Most people in the world use the British Medical Research Council grading system for muscles. Let me explain how those work. If there's no movement at all, not a flicker of movement in an individual muscle, not any movement of the joint, and no palpable movement of the muscle involved, we'll call that a 0. No movement at all. If you can feel the muscle contract under your fingertips, but it doesn't move the joint, we'll call that a 1. If the person can move the joint, but only with gravity eliminated, so I would turn the hand this way and say, move that thumb, so they can move the thumb with gravity eliminated. If you don't eliminate gravity, they can't lift it. Call that a 3. If they can lift it against gravity and resistance, but it isn't normal, it's less than normal, this is a judgment call, you would call it a 4, and if it's normal, we'll call it a 5. It's remarkable the inter-rater reliability of such a simple kind of scale. Most of the time, if I were to say something is a 4, that is, they can move against gravity and resistance, but it isn't normal, another examiner, another experienced neurologist would probably agree with that. Now, of course, this depends on the person trying. They have to try. And if they're not willing to try, then it's much more tricky to be absolutely sure. And I'll show you a trick in a minute of how we can deal with somebody who's putting on weakness, who's trying to exaggerate a deficit. But by and large, it requires our being able to get full cooperation out of the person in order to use this MRC scale of 5. You'll hear some neurologists add pluses and negatives to this, sort of make a 10-point scale out of it. I don't find that helpful. I think that is cutting the apple just too thin, and it isn't really very useful. Now let's examine a few muscles here and show you how this would actually apply. Very often people come with a problem in the upper extremity and you want to examine the brachial plexus. So one good way of doing that is to have you get off the table here, and let's have you turn around and face that way and stand about like that. Put your arms straight out in front of you, Alan, and don't let me push them down. So I'm going to push them down hard. What I'm looking for is whether his scapulae can be held tightly against the wall of his chest. If he were weak, this scapula would wing out. Another way of bringing that out is to have you put the wrist back and push against my hand. And you can see it holds nice and flat against there. Same is true here. You can do the same thing by having the push against the wall. What we're testing is this long, thin muscle, the serratus anterior muscle, commonly affected when there's a brachial plexus problem. Put your hands on your hips now and push back against resistance against me. That's very good. Now we're testing these muscles here, the rhomboid muscles. You can actually feel these muscles contract, push back and relax, push back and relax. And they're very strong. I can't overcome them. You could try that, as you see, on both sides. Another way of testing these rhomboids is to have you put your hand behind your back and push out against me. Push me away. You can see those are not particularly strong muscles. If I get way out on the fulcrum, far from the fulcrum, I can overcome that, but that's normal, completely normal function of those big muscles. Let's test some other more proximal muscles. We're going to ask you to put your arms up against resistance when I tell you to do so. Up against resistance. Go ahead and do it. Relax. Let's do just one side now. It's this muscle here. Relax. Suprascapular muscle is contracting right there. Push out and push back. Very good. Now let's try the infrascapular muscles. Hold it right there. This is the infraspinatus. This is the supraspinatus. Hold that elbow in. I want you to rotate that out against resistance. Push against there. And that's this muscle right inside here, the infraspinatus muscle. I can try that on both sides, but I won't do that. And then cough. Latissimus dorsi. You can see that contracting there. Do it again. See the latissimus dorsi contract on both sides. So we've looked at a number of muscles on the back, supraspinatus, infraspinatus, the rhomboid muscles, the serratus anterior muscle, and these big long muscles of the back. So if somebody had a brachial plexus problem, you'd probably be able to see it there. Then we have the person turn around and face us. Let's have them face. Put your arms out in front of you now and bend them slightly. Very good. Push them together. Push your fists together. Good. That's the pectoralis major that you can see contracting there that I'm testing. Push them together. Very good. Now what I'd like you to do is put your arms up about that high and raise this one against resistance. This is the deltoid muscle. Raise it up hard. That's this deltoid muscle right there, the lateral deltoid. Do it on the other side. Hands out in front of you. Raise that muscle against resistance. Raise it right up. That's it. Good. Perfect. Raise it right up against resistance. That's the anterior deltoid muscle that I'm feeling right here around the shoulder. Good. Now bend your arms. And don't let me straighten it out. This is the biceps brachii right here. Don't let me straighten that out. Don't let me straighten that out. Very good. Now straighten that arm all the way out and don't let me bend it. This is the triceps muscle. The triceps muscle here. Now hold your arms against your sides again, the elbows against your sides. I want you to lift that against resistance. Push it up. Here it is. The brachioradialis muscle. Do you see it there? Brachioradialis muscle there. Good. Turn your arms over like this and don't let me turn them back. These are the pronators. Turn them out like that and don't let me turn them over. These are the supinators of the wrist. very strong. Hold your wrist back in a fist. Don't let me push them down. These are the extensors of the wrist. Fingers out like that. Don't let me push them down. Extensors of the fingers. Can you make that movement? These are the lumbricals. Do that on this side. Very good. Turn your hand over and open them up, and don't let me move those around. Don't hold them really stiff. These little muscles of the hand. And then if you come back to the thumb, you can really test all the major nerves of the thumb by just of the hand by just measuring the thumb strength. So let's do this movement again, up like that. Hold it up, median nerve muscle. Flex that first joint and don't let me straighten it out. Another median nerve muscle. Push that finger against that little finger and don't let me pull it out. This is the opponent's, another median nerve muscle. These are all muscles inside this thenar eminence here. And I want you to turn that over and hold it up. And don't let me push it down. Don't let me push it down. Don't let me push it down. Very good. Perfect. And then turn your hand over and push with that little finger, that finger out there. See that muscle expanding right there? First dorsal interosseous muscle, an ulnar nerve mediated muscle. So we can test all those individual muscles. Now we would only do that if the person really had a complaint that was related to that problem. Let me see you do a deep knee bend and then come back up. Strength of the proximal hips. Stand straight up without, that's very good. A lot of people will tell you, I'm trouble going downstairs, trouble going upstairs, trouble getting up off the toilet without using my hands. That would indicate to you there's probably some weakness of the proximal hips. Let's have you lie down here for a minute and let's test some muscles lying down in the lower extremity. So lie right down. Lift this leg up and just hold it up. We're looking for drift now, very analogous to what I showed you in the upper extremity. 10 seconds in that position. Doesn't drift. I'm not going to do it on the other side. Put it down. Lift that leg against resistance. The iliopsoas muscle, very strong. Let's see you do it again. Very good. Push your legs together. Hard, really hard. The adductors of the leg, obturator nerve, very strong. Hold your toes up that way and don't let me put them down. These are these anterior tibial muscles here, these big ones that are standing out, very strong. Push down on the gas pedal, very strong. That's the gastroc soleus compartment back here. Push out against me. These are the everters. Push in against me, the inverters. Push in against me, inverters. Push out against me, everters of the leg. Now let's say somebody comes to you and they say, I'm weak in one leg, and yet when you watch them walk, you're a little suspicious about it. Let me teach you something called the Hoover test or the Hoover maneuver. Hoover was actually a general practitioner in Cleveland, and he reported this test, which a lot of us use, to try to decide whether a kind of weakness is real. The concept of it is very simple. When a normal person tries to push up with one leg, they push down with the other leg. Let me prove that to you. Lift up against me, strong power, that left leg. You'll see how powerful the other one is contracting. I can't overcome that right one. So what I say to people is, I'm going to test he says he's paralyzed in the right leg, can't move it. I go to test it and I say push down, and he can't push down. He says, I can't push down. You say, try really hard, can't push down. So I said, well, let me test the strong leg. And I subtly put my hand under the paralyzed leg and I say, push up. And lo and behold, I can lift this guy on his head, right, by that pushing down, enormous power of pushing down of his right leg. So I've demonstrated to myself that right leg is not paralyzed. Most people don't realize this is happening to them. Good. Now you can sit up. That can be done on the upper extremity. If somebody says they have a paralyzed right arm, you can take a similar stance. You can have them push together. Put your hands together. I want you to push together as hard as you can, and you go to pull like that. So now imagine a person who says to you, I'm very weak in my right arm, and let me test it. I go to test this right arm. It's very weak. I say, push. The guy says, I can't push. You say, well, all right, let's test your good arm. Push with your good arm as strong as you can. And I'm actually pulling on that weak arm, you see. And I can't overcome the enormous power of his so-called weak right arm. It's very difficult for people to make a midline motion like this and not engage both sides. So you could sort of get around the idea of somebody trying to tell you that they're weak when they're not weak. So that's power. Now tone is a real art, more than a science. Muscles have an inherent tone to them. If you take a limb and you say to the person, relax completely, I want you to really relax, let me do all the work, and you move it passively, a normal person like this actually has very little tone, but it's not zero. That is to say, you notice I sort of close my eyes when I do this. I don't know why I close my eyes. It helps me to feel it better. What it feels like to move a normal limb passively. Very low tone, but not zero. If you've ever felt somebody who has reduced tone, let's say he was in a, God forbid, in a horrible motorcycle accident and he tore all the brachial plexus apart and didn't have any innervation to this arm would be flaccid. And when I moved it, it would be like moving a rag doll. It would not feel normal. That would be decreased tone. Cerebellar disease also produces decreased tone, but not so dramatically so. Then there's normal tone, that's what he has, a little bit of tone, not decreased, and then there's increased tone. So I go to bend this limb, and it feels stiff to me. Sometimes a good way of doing this in some people is to do it with their head and neck. So you say, relax completely, let me move your head around. That's fairly relaxed. Not zero tone, but pretty good. Some people just can't relax. You move that and it's just stiff. Now it turns out there's three kinds of increased tone or stiffness or rigidity. Those are all synonyms. One is called spasticity. Spasticity is a velocity-dependent stiffness, meaning if I move the limb quickly, it will be stiff. So if I go to bend it, I would feel it catch, and then it would give. If I move it slowly, it tends not to be stiff. Velocity-dependent stiffness, that's spasticity. And spasticity is a sign of supranuclear disease of the corticospinal tracts, the kind of thing you'd see in an MS patient or a stroke patient. So you move the limb quickly, it'll catch. Move the limb slowly, it doesn't catch. We could sometimes call that clasped knife, because if it's like bending a knife, it catches and then it gives like a clasped knife. Clasp knife stiffness. Second kind of stiffness is completely independent of velocity. I take the limb, I move it slowly, it's stiff. I move it quickly, it's stiff. It's always stiff. It's like bending a lead pipe, and so we call it lead pipe stiffness. Lead pipe stiffness is the kind of thing you see in extrapyramidal diseases, and the prototype there would be Parkinsonism. Parkinsonism produces lead pipe stiffness, whether it's Parkinson's disease or drug-induced Parkinsonism or some other disease that produces Parkinsonism. It's a different kind of stiffness. And if I superimpose a tremor on that kind of lead pipe stiffness, here I'm bending this, it's stiff, imagine it being stiff, and let's put a tremor on it. Do you feel that? Doesn't actually make that sound, of course. I'm making the sound for you, adding a little sound effects. That is called cogwheeling. Cogwheeling is a tremor superimposed on a kind of stiffness. So in Parkinson's disease, where we have stiffness and tremor, we often feel this cogwheeling. You often feel that in the neck. Move the person around, you can feel this sort of tremor superimposed on the stiffness. And the third kind of stiffness is a very interesting one we call peritonic rigidity. It's a kind of rigidity which varies in severity with the effort of the examiner. I did not misspeak there. It's my mental effort which determines how stiff he's going to get. It has to do with the reaction between the two of us. So what I want you to do, Alan, I want you to make believe that you had a stroke. Your arm is in this position, very stiff, spastic, can't move it, and I'm going to test you. But actually you're faking. You're faking. You've had an accident at work, and you're trying to get out of work. And but I don't know that, and I'm trying to figure out whether this is really an injury to your brain or whether you're putting it on. So try to fake it. Try to fake that weakness of that arm, and let me just move you passively. Remember, you're weak and stiff. So you'll notice that when I pull hard, he pushes hard. And if I don't pull hard, he doesn't push hard. The more I pay attention to, the worse he gets. I mean, for example, do you follow the Patriots?
Yes.
How are they doing this year?
They're doing pretty well. They could be doing better. They're
Don't
not
forget you're supposed to be stiff in the arm.
Oh, right.
See, when we talk about something else, it goes away. When I talk about this, it comes back. When I push, he pulls. When I pull, he pushes. It's a very specific feeling when you're examining a person like this. That's factitious weakness. That's a person trying to look like they're weak and stiff when in fact they haven't had a stroke or a brain injury. It's called Gegenhalten. Now the trick about it, Gegenhalten means paratonia. The problem is that there are real organic brain lesions that cause that same kind of stiffness. And those are frontal lobe lesions. And so you have to decide, do I think it's a frontal lobe disease, or do I think that the person is putting this on for some reason or another? So those are a few tricks to try to separate what you might think of as organic weakness from psychogenic kinds of weakness. So that's tone. Power, tone. Bulk and the appearance of the muscle. So what we should do is we should actually look at the muscle, feel the muscle, and hit it with the reflex hammer. So let's look at some muscles in the upper extremity. Here's a brachioradialis muscle here. You can feel that muscle. You have to get used to what it feels like to feel a normal muscle. It's not wasted, it isn't thin. Let's hit it directly and see what it does. You can see I can make it jump by hitting it directly. This is a so-called myotatic reflex, or a direct muscle excitability. When I hit a muscle, I can activate those sodium channels, I can make the muscle contract. This is not a reflex. We're coming to reflexes, we'll do that later. This is a direct muscle excitability. This is a very useful thing to do, because if this muscle were weak and he couldn't use the brachioradialis, I would wonder, is it a nerve damage or is it a muscle problem? So I would tap directly on the muscle. If this reflex were absent, I would think maybe this is a muscle problem, a myopathy. Whereas if this reflex is intact, I would think, well, maybe it's a nerve problem, and then I would go on and test the actual reflexes, which we'll talk about in another segment. In any case, there's direct muscle excitability. You have to learn to see what muscles look like. What do they look like? The thenar eminence, a nice bulge there. Notice, I'm 64 years old, he's 33. We both have a reasonable thenar eminence, right? Even though his biceps much bigger than my biceps. It's best to look at these small muscles if you want to decide is something wrong with somebody, as opposed to in good shape versus not in good shape, or just a person with big muscles versus small muscles. Look at these small muscles. Are they thinner than they should be? Now there's something here that's very important, and that is, what does it mean to see spontaneous activity of a muscle? This blends in with the problem of the whole issue of movement disorder. What might we see by just looking at him, watching him, or looking at the muscles? Well, you might see the muscles contracting spontaneously. Probably all of us have experienced this, where a muscle will twitch. Very common place for this to happen is around the eye, where for a few days the eye will be twitching. That actually is a motor unit that's acting up. It's a motor neuron, its axon, all of the muscle fibers attached to that one motor neuron fire at once, and the muscle does that. Now that's called a fasciculation. Fasciculations are only meaningful in the context of weakness and wasting. So if I were to see fasciculations in a muscle that otherwise was normal, I wouldn't worry about it. A lot of people, of course, do worry about it. A lot of patients do, particularly, of course, when the patients are medically sophisticated. Doctors and nurses and the like, because they'll worry that they have ALS, motor neuron disease, because they will have read that people with motor neuron disease have fasciculations. And they do, of course, have fasciculations, but that's not the problem, is it? The problem is not the fasciculation. The problem is that those patients have weakness and wasting. They have a motor neuron disease, a lower motor neuron or infranuclear disease, as opposed to the supranuclear problems that we've already talked about. You should also stand back and notice, as you're taking the history and doing your exam, are there any movements that shouldn't be there? So you're looking at the person, and of course all of us are adjusting ourselves, and we're blinking and perhaps sighing and making deep breaths. All that's sort of within normal limits, but what if you see too much of that? Well, this is, of course, an art. When do you begin to say to yourself, I think there are too many movements? What you're seeing in me now is what we would call chorea, a kind of dance, which is what chorea means. Too many movements. It's as if the rheostat has been turned up and the usual number of spontaneous movements have become increased in number. And there's a whole array of such movement disorders, the most important of which would be myoclonus, quick jerks, chorea, semi-voluntary looking movements of this type, often incorporated into normal movements. Big chorea, sometimes called ballism, where a limb goes flinging off into space. Twisting movements into abnormal postures, so-called dystonias. Moving dystonias, called athetosis, snake-like movements from one twisted posture to another twisted posture. Akathisia, there's the inability to stand still, constant ruminating and moving about. And finally, tics. Tics are habits. They're things that we do which are semi-voluntary, like clearing our throat, sniffling, and sometimes making odd sounds. And of course, it's normal if there's a minimum number of these, but if they become very exaggerated, then you have a disease that is sometimes called the Georges-Gilles-Tourette syndrome. So movement disorders are a spectrum. You have to stand back and decide, where is the rheostat set? Is it too high? Is it just right? Or is it too low? Is the limb stiff and slow? Are there too few spontaneous movements? How would I notice that? Well, the best way is in the face. You're watching this person, and as you're talking to this person, you notice he's not blinking often enough. He's not moving the corners of his mouth the way normal people do. When he stands, he tends to be flexed forward and doesn't stand up straight. And when he walks, he doesn't swing his arms normally. This would be known as bradykinesia. And bradykinesia is another word for what most people would call Parkinsonism. It's that kind of extrapyramidal paucity of spontaneous movements. So it's a spectrum, isn't it, from no movement, akinesia, to too little movement, bradykinesia, to just right, to too many, myoclonus and chorea and athetosis and dystonia and tics. And to recognize these things takes time, takes skill. You have to understand how much you allow within normal limits. What we're looking at here, of course, is a normal person. He has a normal facial expression. He does adjust himself. He does blink his eyes, but not too much, not too little. As the Three Little Bears would say, just right. Just right. That's what we want to look for. So we're looking for spontaneous movements or too little movement. So let me review what the motor examination is. It's an examination of power on a scale of 0 to 5, the Medical Research Council scale of 0 to 5. Bulk and appearance, the appearance of the muscles and the spontaneous reaction. Tone, that inherent stiffness, which ought to be just right, not increased and not decreased, and then whether or not there are any spontaneous abnormalities of movement, either too little, bradykinesia, or too much, dystonia, chorea, athetosis, tics, and the like. So I hope that gives you a good approach to the motor examination.